This lecture is on schizophrenia and related disorders by Dr. Philip John Tyson, Senior Lecturer in Psychology at the University of South Wales. This lecture is on schizophrenia and related disorders by Dr. Philip John Tyson, Senior Lecturer in Psychology at the University of South Wales. Please read this case study of somebody who develops schizophrenia. You'll see many of the core symptoms displayed, which we will discuss later. The symptoms of schizophrenia have been recognised for hundreds, if not thousands of years. And an interesting early case study is that of James Tilley Matthews, who is the first documented case of paranoid schizophrenia. Matthews believed he was being tormented by a gang of spies who used an heirloom to prevent his blood circulating around his body. You can see a drawing of this heirloom that Matthews made whilst he was in Bedlam Asylum. The first modern definition of schizophrenia was provided by the German psychiatrist Emil Kraepelin. He observed that three previously existing disorders, hebephrenia, catatonia, and dementia paranoids, were actually manifestations of the same underlying condition, and he called this condition dementia praecox. However, around 20 years later, a Swiss psychiatrist, Eugen Bleuler, redefined the disorder as having four primary signs: autism, loosening of associations, ambivalence, and affect inappropriateness. And he thought a better term to describe the condition was schizophrenia, derived from the Greek verb for splitting, schizein, and their noun for mind, phren. And he used the term because he thought a key criteria for the disorder was a split from reality. This lecture will now move on to discuss the symptoms of schizophrenia. And the first ones we'll consider are delusions. Delusions are irrational beliefs which are held despite disconfirming evidence. For example, someone might believe that they are a pop star, the devil, an angel, or God. Many separate types of delusions have been identified, and some of the most common are delusions of persecution, where the individual is being harmed or thinks they've been harmed or persecuted in some way; delusions of grandeur, where the individual believes they've got a special purpose in life; or delusions of control, where the individual believes that someone or something is controlling their thoughts and behaviour. The next class of symptoms to discuss are hallucinations. Now, hallucinations are sensory experiences which are not attributable to the environment. So, for example, somebody might hear a voice when there is nobody there, or see something that no one else can see. In schizophrenia, the most common type of hallucination is an auditory one, which means hearing voices that nobody else can hear. This slide is from a blog by people who hear voices. You can see how some of the voices that these individuals hear can be quite disturbing, such as in the first instance where somebody is accused of being a Nazi. In addition to experiencing auditory hallucinations, people with schizophrenia sometimes report visual hallucinations, where they see things that aren't there; olfactory hallucinations, where they smell things that aren't there; and gustatory hallucinations, where they taste things that are not present. And here are some examples. The third type of symptom to discuss relates to disorganized speech, and here there may be jumbled or incoherent utterances. There may be loose associations, where someone shifts their thread of conversation in an irregular, unexpected way; or there may be neologisms, where the speaker makes up words. And there are examples of these disorganized speech patterns here. The fourth type of symptom described in schizophrenia is grossly disorganized or catatonic behavior. Grossly disorganized behavior can involve displaying highly agitated and unpredictable movements, such as running down the road screaming. Catatonic behavior usually describes situations where there are extremely high or extremely low activity levels. Low activity levels have several behavioral features: social withdrawal, mutism, posturing, catalepsy, and muscle rigidity. Here are some examples of patients showing catatonic behavior. The final class of symptoms to consider are called negative symptoms, and this general term describes a lack of emotion, a lack of spontaneous speech called alogia, and a lack of an ability to take goal-directed action, such as getting out of bed in the morning, and this is called avolition. The complex array of symptoms seen in schizophrenia are often classified in terms of positive and negative symptoms. The positive symptoms being delusions, hallucinations, disorganized thought and speech, and disorganized or catatonic behavior, and the negative symptoms being flat affect, alogia, and avolition. There are several other criteria which need to be met for a diagnosis of schizophrenia. Since the onset of symptoms, function in key areas of life must have been impaired. There must have been signs of the disorder for 6 months or more. Other disorders with psychotic features must be ruled out, and so must the effects of drugs or other potential causes of the disorder, such as a brain tumour. Some studies have shown that those that go on to develop schizophrenia have certain premorbid personality characteristics which can be seen in childhood. For example, they may be an overly anxious child, they may have had difficulty making friends, or they may have struggled academically. Now, prior to the onset of the full-blown disorder, something called a prodromal phase is often observed, and this is where there's a gradual build-up of symptoms over a period of time. For example, eccentric ideas and peculiar behaviours might start to appear, and the individual may withdraw from family and friend contact. Once the full-blown disorder appears, then there are different patterns of illness and wellness observed. And you can see these in figure 13.3 on this slide. The bell-shaped curves represent patterns of illness, and the straight line represents patterns of wellness. So you can see in time course 1, 12.2% of people are very ill for a time period, and then they're well for the rest of their life. In time course 2, there are 3 separate incidences of impairment and illness, but in between time the individuals are well. Time course 3 shows that with each subsequent impairment and episode of illness, the patient is never quite back to normal functioning. Please study this chart very carefully. Long-term outcome studies in schizophrenia have shown that there are several factors associated with better recovery. Women tend to recover better than men, those with high levels of education, those who are married, those who have a good occupational history, those who have independent living skills, those who have lower levels of depression and anxiety, those who have peer support, and those who have early intervention often recover better than those who do not. The next part of this presentation we'll deal with proposed causes of schizophrenia, and we'll first consider biological factors. Now, genetics seems to play an important role in the development of schizophrenia. If you have an identical twin with schizophrenia, then your chance of developing the disorder yourself is about 48%. However, if you don't have a relative with schizophrenia, then your chance of developing the disorder is about 1%. Study this chart carefully. It shows the relative risk that you have of developing schizophrenia as a function of the genes shared with an individual who already suffers from the disorder. So if you have an identical twin with schizophrenia, you've got a 48% chance of developing the disorder, and if you don't have any relative with schizophrenia, then you've got a 1% chance of developing the disorder. The next proposed biological cause of schizophrenia relates to brain structure abnormalities. And one of the first observable brain abnormalities to be detected in this disorder is that of enlarged ventricles. Ventricles are cavities within the brain containing cerebrospinal fluid, and it seems that these areas of the brain are larger in those with schizophrenia in comparison to those without. And you can see the enlarged cavities in these two illustrations here. In addition, it seems that young people with schizophrenia show a loss of grey matter in certain areas of the brain, parietal, temporal and frontal areas. And this essentially means that the brain shrinks and the neurons are lost. You can see this illustrated in the chart here. The third biological theory relating to causes of schizophrenia centres around neurochemical abnormalities, and it seems that an excess of the neurotransmitter dopamine may be to blame for some of the positive symptoms seen in the disorder. There are 3 lines of evidence in support of this suggestion, as shown here. This illustration shows the effects of an antipsychotic risperidone on symptoms of schizophrenia, and you can see that with 4 milligrams of risperidone, looking at the scale at the bottom of the page, then there's an antipsychotic action and the voices are gone. But if you move to the right along the bottom scale, you'll see that when you get to 7 milligrams of risperidone a day, there's something called Parkinsonism action, which means that there's a motor deficit observed and the client may demonstrate a tremor. However, the dopamine hypothesis does not offer an all-encompassing explanation for schizophrenia. Lots of research has shown that up to 30% of patients with the disorder do not respond to treatment with this medication, and it seems that other neurotransmitters may be involved in the pathology, such as serotonin, noradrenaline and glutamate. Moving on now to environmental factors which may be to blame for schizophrenia, and birth complications and hazards seem to play a role. Studies have found that prematurity, low levels of oxygen to the brain at birth, needing resuscitation or incubatory care, and a low birth weight all seem to carry increased risk. Other environmental factors which seem to predispose somebody to developing schizophrenia involve things related to upbringing. So for example, if you're from a low socioeconomic group, if you live in an urban environment, if you've suffered stress or maltreatment as a child, then all of these factors give you an increased risk of developing the disorder. This final section of the presentation will deal with treatments for schizophrenia and related disorders, and the first ones to discuss are biologically based treatments. Now, antipsychotic medication was discovered in the 1950s, and it seemed to play an important role in reducing symptoms, particularly positive symptoms. Early antipsychotics included chlorpromazine, flupentixol, and haloperidol. However, one of the problems with the first generation of antipsychotic medication is that they caused a number of motor side effects. This led to the search for other compounds which would have the same antipsychotic effect but which would not have the same side effect profile. Clozapine, olanzapine, risperidone are three of these new types of medication which are called atypical antipsychotics. This chart displays a comparison of 15 different antipsychotic drugs on the symptoms of schizophrenia, and essentially looking at the lines in the central part of the chart, the further they are towards the left, the more beneficial they are for patients with schizophrenia. And you can see at the top that clozapine seems to be the most effective. This chart also shows a comparison of 15 different antipsychotic drugs. However, the focus here is on extrapyramidal side effects or motor side effects. And you can see, looking at the bottom of the chart, that haloperidol seems to have the most side effects. Weight gain is another side effect of antipsychotic medication, and this final chart shows a comparison of the weight gain to different antipsychotic drugs. And again, looking at the bottom of the chart, you'll see that olanzapine and zotapine, clozapine induces more weight gain than drugs such as haloperidol or ziprasidone. Moving on now to psychological treatments for schizophrenia, and cognitive behavioural therapy is often used. One of the ways it's used is to encourage behavioural change, such as helping individuals with negative symptoms become more active, and it also can be used in a cognitive sense to help individuals challenge their hallucinations and delusions. There's a reasonable evidence base for the efficacy of CBT in schizophrenia. However, it seems that if the symptoms are very severe, then CBT is less effective. This chart summarises some of the main techniques used within CBT for people with schizophrenia. For example, one of the techniques to use for hallucinations would be to help people cope with those hallucinations. For negative symptoms, there are a whole range of behavioural interventions which might work. Family communication and education are also important targets for psychological therapy. It's well established that negative communication patterns within the family puts individuals at greater risk of relapse if they already have the disorder, and essentially enhanced and positive communication is very, very important, not only for the individual concerned with the disorder, but also to reduce stress within the whole family environment. In addition to schizophrenia in the DSM-5, there are several other psychotic disorders which are worthy of mention. Schizophreniform disorder, brief psychotic disorder, schizoaffective disorder, and delusional disorder, and you can read about the main symptoms of these here. Please click on this link to see a psychotic episode as described by somebody with schizophrenia.